and we talked about some of the medication, and we said prazole and tadine. Everyone is all right with those drugs? We talked about it. Now I'm going to go on surgical, on page number is 6. We finished up till prazole and all that we have done, and we talked about Zantac and cimetidine. Those we did. Let's move on, page number 6, antacids. Questions on antacids we all should know. We give them patients on a regular basis. Very important, the last line, everyone must know. You do not combine with other medication, antacids. So last line on antacids, page number 6 is the last line. Allow 1 hour between antacids and other medications. So if you're giving antacids, don't give with other medication. Why? Because they lower the effect of the medication. Everyone is okay? Now you can read it more, you can shake them, you can give them when, but very important, don't combine antacids with other drugs. I will move on. The kinds of antacids we have here are ammonium hydroxide. What is another name for ammonium hydroxide? Amphogel. So make sure we write it down, amphogel. Amphogel is same. Sometimes they give amphogel. What is amphogel? Is ammonium hydroxide. What do you monitor? Everyone should know 2 words here. Second line, constipation. And the last word, correct the spelling, hypo. Hypo. Hypo, and it says phosphatemia. Phosphate level, it lowers. So everyone must know ammonium hydroxide is an antacid. You're giving amphogel. What does it lower here? Is phosphate level. What does it cause? Constipation. It's antacid, and you're giving to the patient when they have ulcer, and amphogel monitor for phosphate level. Calcium carbonate. What does it cause? Underline the word constipation, the last line. And also it can cause is fatigue and headache. But we must know ammonium and calcium, they both cause constipation. Let's go, the third one is magnesium. Magnesium is more as saline laxative in the second line. So what is magnesium hydroxides are? They are saline laxative, and what are you monitoring here are diarrhea. So magnesium are the one causing diarrhea, and very careful with renal impairment. That means renal disease. So if you're giving magnesium, patient is taking, and they have kidney problem, you got to be careful because it can cause toxicity. Soda bicarb is also antacids, but underline the word, you are treating acidosis, the last line. What acidosis? Metabolic acidosis. And client education for ulcer patients are, what do you teach client, those who have ulcer? We discussed the kind of ulcer, we talked about the medication, we talked about antacid. Now I'm moving on, is client education. Avoid caffeine, chocolate, alcohol, smoking. Avoid medication if they have ulcer, such as aspirin, such as NSAID, and add their steroids. Avoid the steroids because steroids is affecting the GI bleeding. So what drug we avoid here? Aspirin, NSAID, and what else we said? A steroid. Avoid a stress reduction. Diet, blend diet. What do you monitor? We said earlier, shock. What kind of shock? Because they're bleeding, hypovolemic shock. Now, your question, if patient is having GI bleeding, what would you do for GI bleeding? I want you to highlight the word irrigation. And what is the word is called for irrigation? Lavage. Everyone is okay? What is lavage is? Irrigation. Lavage is irrigation, gavage is feeding. We must know the difference between those 2 words. Lavage means if they give you a question, patient has ulcer, patient is bleeding, what would you do? The first answer, you irrigate the tube. How? with cold, ice cold, normal saline. The best is saline because it has more body fluid similar with the sodium. So what are we irrigating with? Normal saline. Second answer, you are giving vasopressin or pitracin is important medication. Pitracin is, we are using where? Where else do we use? For diabetes insipidus. Write down the word. And what is the effect of pitracin is vasoconstrictor. Everyone is all right? Patient is bleeding. What do we do? Lavage. What is the word lavage is? You are irrigating the tube with what? Normal saline. And second thing we said, we can give the medication. And what medication you will pick up here? Vasopressin and pitracin. The effect of the medication is what? Vasoconstrictor. Now I'm going to move on the next page is surgical intervention. What are surgical intervention we have? The first word is gastrectomy. Whenever you see the word gastrectomy, what is gastrectomy? Gastric means the stomach. They're removing the part of the stomach or completely stomach. So what is gastrectomy? Addressing with the stomach problem. Vagotomy word. What is vagotomy? Underline the word vagus nerve. Why they're removing the vagus nerve? To decrease and impulses, eliminating. Eliminating means decreasing the impulses of what? And of the vagus nerve. And what is it decreasing here? Hydrochloric acid. So what is vagotomy means? Removing the vagus nerve. And what does the vagus nerves are doing? Decreasing the hydrochloric acid. Gastric word resection. The resection word is you are cutting the part of the stomach. Enterectomy word also they can give. So everyone should know gastrectomy word, gastric resection word, enterectomy word, that they remove the part of the stomach and they're joining with the intestine. Another word is very important is Bilirubin 1 and Bilirubin 2. What is Bilirubin 1? They cut the part of the stomach and they're joining with the small intestine. What is the first part of the small intestine? You have duodenum. And the next part is jejunum. So they remove the part of the stomach and their anastomosis means they're joining and they're joining together with the intestine. When they're saying Bilirubin 1, that is also called gastroduodenostomy. What is gastro means stomach and they're joining with what? Duodenum. What is Bilirubin 2? Gastrojejunostomy. What is the meaning gastrojejunostomy? They remove the part of the stomach where they have ulcer and they're joining with what here? With jejunum. And pyloroplasty. What is the pyloroplasty? The lower part of the stomach is called pyloric area. And what are they doing here is decreasing obstruction. So what happened? The narrowing of the pyloric area because of the ulcers, they are widening up. They are opening it up and to preventing what is the food to pass through. Now these are surgery can be done when patient has ulcers. Everyone is okay? The wording is important. Everyone should know. When do they do Bilirubin 1 and Bilirubin 2? Gastrectomy word, vagotomy word, pyloroplasty word, all that go in GI surgery. Now these are main wording. I want everyone, we all know we prepare patient going for surgery, but what do you do after patient come back from gastric surgery? Post-op is very important. What do we do with post-op care patients are? Number one. What do we do? Number one, I want you, we all highlight the word NPO. First thing is remember, patient who's coming back with gastric surgery, NPO. Don't give anything by mouth. When they're coming back by NPO, what do they have? The last line, it says NG tube for suction. So what does the patient come back here is NG tube, and what do we have NG tube? Not to feed, remember, for suction. What is the meaning suction? They're removing the fluid from the stomach. Why? To prevent the pressure in the stomach. Now what will happen if we don't take out the fluid from the stomach? The stomach will cause what? We use the word distension. It's going to cause what? Bloating and distension. So what will happen if it distended? That you're going to cause pressure on the suture line in the stomach area. So what they have done, patient has got the surgery done, patient is coming back. In our mind, what do we do? First thing, patient is NPO. And what is the second thing is important here? NG tube suction. And when you're questioned with NG tube suction, I will talk here separately. But first, let's line up all the treatment. What position would be good? Whenever you have suction, you want your patient in semi-Fowler's position. Why? Because the fluid is coming out by gravity. And that would be good in fluid to be coming out through the stomach. So what position you put the patient here? Semi-Fowler's. Patient has NG2 suction. And what do you monitor here? NPO until peristalsis return. So if any question, now doctor has ordered to remove NG tube. When would you start the food to your patient? Now the question, doctor has ordered to remove NG tube, but you are going to start feeding your patient. So when do you start feeding your patient? When peristalsis return. If they give you a word paralytic ileus, what is paralytic ileus? You cannot give food. Why? Because there is no peristalsis. So they may not use the word bowel sound. What is another word is peristalsis. And paralytic ileus means there is no bowel sound and the food is not passing. Monitor vital sign, we all know. When you start food, what do you start? All after surgery with clear water or maybe clear liquid diet. Do not irrigate or remove the tube until the doctor has ordered or you are assisting with the doctor. Now let me go back here for suction question. If they give you patient has NG tube with suction, what is your responsibility as a nurse? What is our responsibility? We must measure the suction bottle. Are you going to check suction bottle whether it's draining or not? Yes. So remember, the patient has here the suction bottle. So what are we monitoring here is output. And what do you monitor? How much is the drainage bottle contains? When do you check and when do you record all your fluid before you're retiring from your job? That means end of your shift. Don't ever pick up answer when the bottle is full, because every nurse need to know if how much fluid is coming. If there is a question, there is no fluid is coming out through the tubing, what does it mean? Or there may be a question, there's nothing in the drainage bottle. What does it mean? The tube is not patent. So what do you do? Don't call the doctor. Don't call your RN. What do you do? Check your patient. And what are you checking for your patient? For patency of the tube. Maybe your answer, turn the patient on different positions. Sometimes what happens, patient is laying and the tube may be not in a good position. Maybe answer, what do you do? Reposition the patient. Maybe your answer to check the king. Maybe answer to see if your suction machine is working. Everyone is okay? So what is your job is here? To monitor the suction. And where do you record when you empty? It's an output. You got to know how much fluid is coming out. So everyone is okay? Gastrectomy, Bilroot 1, Bilroot 2 is a stomach surgery. Now I'm going to go in complication. Now what happened? When they remove the part of the stomach, the fluid, the stomach is very small. And what would happen to the patient? So after gastrectomy, everyone should know you're monitoring your patient's complication and underline the word dumping syndrome. What are the complications are? Dumping syndrome. everyone should know dumping syndrome. Number 2 is pernicious anemia. And the word it says here, B12 deficiency. Second complication we can highlight because they're not getting enough food absorbed. It can lead to hypoglycemia. But everyone should know dumping syndrome and pernicious anemia, 2 complications. Now I'm going to move on is dumping syndrome. What is dumping syndrome? In complication, second line. What happens when patient's stomach is small? The food is rapid emptying of the gastric food or gastric content into small intestine. So what happened? The food is not staying longer in the stomach and the food is passing quickly where? In the intestine. So patient developed the symptom of dumping syndrome. So what is dumping syndrome? How do we define rapid emptying of the gastric content into the intestine? What do you monitor your patient when they have dumping syndrome? Now you have nausea, vomiting in the last line. We all know patient would have nausea, vomiting. It's a stomach problem. But I want everyone, second one is important. As soon as the food comes in the stomach, patients start feeling palpitation. Highlight the word palpitation. Second word, they start feeling tachycardia and perspiration, and patient colors become pallor. So second, third, and fourth one is important. Palpitation, tachycardia, patient is having perspiration, dizziness, and pallor. We all know abdominal cramping. So whenever I review and I say, what is dumping syndrome? You know, complication after gastrectomy or Billroth 1 and Billroth 2. What do we monitor patient here when patient has gastrectomy or dumping syndrome? What is dumping syndrome? Sign and symptoms are palpitation, tachycardia, and I want perspiration. The colors become very pale. Patient complain dizziness. These are main symptoms, and everyone must know those 3 symptoms. And we all know it's going to affect the stomach, it's going to cause nausea and vomiting, upset stomach. And now our teaching question. What do you teach? Everyone must know this is the one condition where you do not raise the head of the bed. What did I said earlier this morning? That what position you're raising the head of the bed in GERD and hiatal hernia. Everyone is okay? Now what position are we going here? If you go is third line, recumbent. What is recumbent means on the back. Are we clear? Do not raise the head. You may use one pillow, that's okay, but do not pick up and raise the head of the bed. Why? If you raise the head of the bed, the food is going to pass very quickly. And so what position do you put the patient? Laying on back may be in your answer, recumbent position. So everyone, number 1 position. We all must know, your question comes, remember, in exam, all that apply. So we need to know more than one question, is what kind of diet do you cut down? I did write here to increase, but remember, we are cutting down carb. What diet we cut down? Carb. So if it says increase protein, increase fat, that's okay. But wherever you see decreasing carb, we got to decrease carb. Why? Because it digests faster and you are decreasing carb. So that's number 2. And third thing, what are we decreasing here are the fluids. And when does the patient should drink fluid? After the meal, not with meal, maybe after an hour. If they say patient must drink water after 1 hour, that's okay, pick up that answer. But if they say patient must drink water with their meals, you don't pick up that. So what are the third thing I said is important is the fluid. What is the first thing? Recumbent position. Second thing I said is what do we cut down in the diet? Carb. You can increase protein, you can increase fat, but what are we cutting down here? Carb. And what do you give the patient? Because they can handle a lot of food. Always small, frequent meals are good. And also small frequent meals, you can give them And medication are antispasmodic. Why? They have a lot of spasm, and underline the word bentyl and probenthine. So there are two drugs are here, bentyl and probenthine. You can give them. And when do you give? Before patient is eating, because what does it help here? To cut down the spasm. Avoid sugar, salt, and milk. Everyone should know dumping syndrome, position, and the fluid and the diet. And the medication are probenthine, I said, and bentyl, and that helps them for the pain and the spasm. Next page, we will move on, page number 8, is pernicious anemia. So I said two complications, dumping syndrome and pernicious anemia. What is the sign why patient has pernicious anemia? Underline the word deficiency of what? Intrinsic factor. And what would you do the testing? What test do you do for pernicious anemia? Is Schilling test. And you're collecting the urine specimen. So everyone can have their Schilling test. Where do we do the Schilling test? To diagnose for pernicious anemia. And as a nurses, what are we collecting here? The urine specimen. Intervention. Before intervention, let's see some sign and symptom of pernicious anemia. Everyone must know on your assessment. Your questions are, when you are admitting your patient who has pernicious anemia, what would you assess? Underline the word beefy tongue, a smooth, beefy, red tongue. Second thing is paresthesia word. And paresthesia word in tingling sensation of hand and feet. And also add their lack of sensation of position. So lack of position, that they don't know what position they are, is used also, lack for position sensation. So add there. I have come across some of your question and the answer because of the nerve, and they have lack of sensation of the position. Now we all remember anemia lead to what? Fatigue. We all know when you're anemic, what are the other symptoms? We all should know. Whatever the anemia, the kinds of anemia, patients are going to be very tired easily. And fatigue is there, losing weight is there, and lead to jaundice. Everyone should know, because you're destroying is on not a lot of red blood cells here. And patients with pernicious anemia also is you monitor for jaundice. Everyone is okay? Beefy tongue, paresthesia, and lack of positioning sensation. They get tired and jaundice. What is the intervention are? You are treating them with what? B12 injection. How do we give B12 injection? IM. How often do you give B12 injection? Once a month. Everyone should know once a month. But first they start, they give weekly for 1 month, and then they continue monthly for whole life. All their life they would need it, because they will not have enough B12. The food, I have something here with the diet. Food rich in B12 are your citrus fruits, dried greens, green leafy vegetable, and also organ meat and liver. So you do need to learn some of your diet questions for all your anemia patients, B12 deficiency. Everyone is okay about pernicious anemia and deficiency. So what are the two complications after Bilirubin 1, Bilirubin 2, or gastrectomy? What are the two complications? Dumping syndrome and pernicious anemia. What is the position for dumping syndrome? Recumbent. Very good. What do you cut down in the diet? Carb and fluids. We got to cut down the carb and the fluids. So we need to cut down the carb and the fluids. Now I'm going to move on liver cirrhosis. Is on the patient's question with liver cirrhosis. Now what is in liver cirrhosis are, first thing is the bleeding. And we have here is esophageal bleeding. So underline, patient with liver cirrhosis, they're bleeding, esophageal bleeding. And what are the reasons for bleeding here is the second line, portal hypertension. So we have patient with liver problem. And what is the first thing is, I said, is the bleeding. And what is the reason for bleeding is here is portal hypertension. Portal hypertension. We all should know the reason. Portal. Portal means liver. And liver cirrhosis patient, they are bleeding. And second thing, I want you to highlight, the goal is control the bleeding. Patient is bleeding, we got to control the bleeding. Data collection. What do we do when patient is bleeding? Number one, we said portal hypertension and bleeding, and where they're bleeding, we said esophagus and esophageal. I want you to underline hematemesis. Hematemesis means they're vomiting. Second word, melena. That means their bleeding is also in the stool. So patients are bleeding all over. So patient has liver cirrhosis, what are they are? They're bleeding. Everyone must know, number one problem, bleeding. Where are they bleeding? Esophageal, number one. They're bleeding all over, and if they're saying patient is admitted with hematemesis, that means they're bleeding. Melena means they're bleeding. And tarry stool means the color of the stool is changed and patient is bleeding. Next word, we have ascites. That's number two. We all must know the patient has ascites. And what is ascites? We discussed earlier, they are having fluid in where? Peritoneal cavity. So what do we have here? Fluid in the peritoneal cavity. So everyone is okay? Ascites word. And then you will go, what is, whenever we are saying word ascites, whether you're going in CHF or liver cirrhosis, when the fluid is in the stomach, and what organs can be affected when patient has ascites is you have liver, and what is liver is called hepatomegaly. Everyone is okay? Hepatomegaly and a splenomegaly. Everyone is all right? When the liver is affected and patient has ascites, never forget, whenever we have ascites, the organs are affected. What organs are affected? Hepatomegaly and splenomegaly. Next line, I want you to, third line is acetoraxis word. What is acetoraxis word are? Acetoraxis word is flapping tremor. What is a flapping tremor? Word is non-rhythmic extension and flexion of the wrist and the finger. So if you tell them to keep their hands straight, they can keep it, and what they're going, non-rhythmic flexion, this is word flexion and extension. So they cannot keep their hands straight and the fingers because of the damage of the nerve. So the word is called neuropathy. So I want you to add their word is neuropathy. Neuropathy. And the next word you have encephalopathy. Everyone highlight the word encephalopathy. So patient is having liver cirrhosis. What are we monitoring? Number one, we can memorize is patient is bleeding all over. And what did I said is patient has bleeding, esophageal varices. And what does the patient has? They're vomiting blood, and it's called hematemesis, melena, tarry stool, ascites. In ascites, what did I said? Hepatomegaly and splenomegaly. Patient has both their problem with the organs, the liver and the spleen. Acetoraxis word is what? We all know flapping tremor, but I like it, we must know acetoraxis word. And what is that means is non-rhythmic flexion and extension. There's no rhythm. They can't keep their hands straight. And what does it mean? It's affecting neuropathy. And what is another word is encephalopathy. Whenever we get the word encephalopathy, what do we monitor is level of consciousness. That means is affecting the brain. And what do you monitor? Level of consciousness and neurological assessment. Wording makes a lot of difference. Once we know the wording, and we are saying encephalopathy means is what level of consciousness, and you're monitoring neurological assessment. Next word is smell. What kind of smell they have is called fatter hepaticus. Fatter means fruity smell. So underline fatter. Fatter hepaticus means fruity smell. Then I want you to underline the word spider angioma and edema. So remember, they have ascites, and also they have here edema all over, and patient is admitted with edema and ascites. And number 7 is, and you can highlight the word spider angioma. What is spider angioma word is, their blood vessels are very dilated, like a spider web. So it's called spider angioma. Sometimes they throw the pictures, and the pictures are because patients are very skinny, all the blood vessels, they are more dilated, is spider angioma. Next word is caput midiscal. The last word, MEDUSAE, you can add. When they give the word caput midiscal, that means they're bruising. And where is the bruise? Around umbilical area. Because they're bleeding all over, they have easily bruising, and they have underlined the word thrombocytopenia. And they have thrombocytopenia. What is thrombocytopenia? Is affecting the what count? What blood count? Platelet count. And what is platelet does? A clotting system. So patient is risk for bleeding, and patient has thrombocytopenia. They're bleeding all over. There's a bruising word is there. And where is the bruising? We said around the umbilical area. And the word is called caput midiscus. And spider angioma. And increasing sodium, decreasing on increasing, and low calcium. So everyone must know is what is liver cirrhosis. Are the patient with liver cirrhosis, what are the first thing I said is the bleeding. Everyone should remember the word esophageal bleeding, and maybe the patient is vomiting, and maybe melena. Ascites word, we all should know. When the word comes ascites, remember the word hepato and splenomegaly. Third thing is acetoacetus, neuropathy, encephalopathy, and the smell, fatter hepaticus. And edema they have, and a spider angioma. These are all important words. If we will remember, we will do the questions better. We don't have the books. Patient comes in. We must know the problem with liver is going to be a bleeding, ascites, and edema. Everyone is okay? And the word encephalopathy. Management. What do we do when patient is admitted with liver cirrhosis? Number 1, if we have a patient with ascites and edema, we are going to restrict the fluid and sodium. So I want you to write down restrict sodium and fluid. And diet is, if they are not in coma, they are not neurological, we still continue high quality protein. And remember, the vitamins are important for liver are B complex, and vitamin C, vitamin A and K, and folic acid. And also thiamine is important. Now thiamine is also given to the patient, vitamins are given, and protein you can continue, but cut down the salt and the fluid. And monitor INO, maybe they're getting diuretics. A patient is bleeding, esophageal, we did already earlier. What do? We give them is irrigation word and pitocin, and last word is here balloon tamponade. Blackmore catheter, we can put it in to stop bleeding. Everyone is okay? Segmentin Blackmore catheter or tamponade catheter. Why? They insert it, and what do? They apply the pressure. So 3 answers are important. Irrigation you can give, vasopressin you can give, vasoconstrictor, and third thing is balloon tamponade or segmentin Blackmore catheter to stop the bleeding. What do you keep in the room are scissor and you're monitoring for bleeding. Lab, they may do the lab to check the bleeding, coagulation, may be given vitamin K. And the main medication are lactulose. So what are the drugs we are giving here is lactulose to the patient. And number 2, you can give neomycin. And third one is Flagyl. Now, so lactulose is given, underline the word, is decreasing the pH of the bowel. Sometimes they ask, we all know it helps to lower ammonia level, but some of your question, what does decrease here pH of the stool? Now lactulose can be also used as a laxative. So lactulose you're giving to reduce what? Ammonia level. And Flagyl and neomycin is antibiotic. And what do? Underline the word, inhibit protein synthesis. So what is the affecting here? Protein. And in bacteria and decreasing the production of ammonia. So what is Flagyl and neomycin are? They're antibiotic. What are they doing? Decreasing, what are they decreasing? The protein synthesis and decreasing ammonia level. Everyone remember one thing, whenever you have Flagyl is a good antibiotic. They can also use for treating ulcer, but what does you teach the patient? No alcohol. So make sure we write down Flagyl, no alcohol. If patient would take alcohol, they will have severe reaction. If patient is in encephalopathy and affecting the brain, what do we cut down here? Underline the word sedatives and barbiturates. Don't sedate them. Don't give medication. Why? Because they all are going out through the liver. And liver is already damaged. None of the drugs would be able to excrete through the liver, and patient would have more toxicity. Everyone is okay? We talked about the liver cirrhosis. What are the patient has paracentesis? Remember we talked about paracentesis. They remove the fluid. Now what is the type of cirrhosis we have? The word is Lancer. On the next page, number 9, Lancer means is what? Is alcohol. Underline the word for leading by alcohol. And what does it affecting here? The liver tissues. Post-necrotic word is viral. Any infection. Or hepato. Hepato word is liver. Hepatotoxin. So when they're saying hepato, means is liver. Hepatotoxicity of the medication. So if you're taking drugs which are damaging liver or infection, viral hepatitis can lead to damage the liver. Biliary means obstruction of the gallbladder or biliary obstruction. Cirrhosis is from cardiac, is underline the word right side heart failure. So what are the main reasons for liver cirrhosis? Number 1, we said alcohol. Number 2, viral infection, biliary obstruction, and the CHF. So we covered is here all completely liver cirrhosis. Now I'm going to move on. Next on the same page, number 9 is cholecystitis. We must know. So where is the liver? We did earlier. Where is the liver? On the right side upper quadrant, right? Where is the gallbladder? Where is the gallbladder we have? Where is the gallbladder? Where is the gallbladder? Is cholecystitis we are talking, and the gallbladder is also on the right side, right upper quadrant. Liver is right side, gallbladder is right side. When they are saying the word cholecystitis, what is the meaning cholecystitis? The problem with the gallbladder. Everyone is okay? Cholecystitis is gallbladder. When they are saying cholelithiasis is the gallstone. And underline the word is gallbladder is inflammation and caused by diet, maybe drugs, cholesterol medication, diabetic patient, Crohn's disease are very high, they can get, and we have 4F, female, 40, fat, and fertile, okay? So 4F we have with female, 40, fat, and fertile are more risk. Now what would be the patient is complaining? So first thing we must know the wording. Cholecystitis word is with the gallbladder. We must know where is the liver is on the right side. Where is the gallbladder here is on the right side. So let's go on data collection. So patient says what when they have problem in the gallbladder? Indigestion, that the food is not digesting. They may feel a lot of flatulence and the belching of the food. Where is the pain patient has? Here, right upper quadrant. Very important, the pain. And where does it radiate? So where is the pain? Right upper quadrant and radiating to the scapula. Scapula is the shoulder in the back. And so where is the pain is going towards the scapula and right upper quadrant. When patient says, I'm having pain after I'm eating fatty food. I had a big hamburger and fries and I start having pain. Could be the gallbladder. So what is the problem here? Digestion of fat. Are we okay? And where is the pain? Everyone should know in gallbladder is the right upper quadrant. And where is the pain is radiating to the right scapula or shoulder. Second thing is, important is, you can feel the mass. And where do you feel the mass would be in the right upper quadrant. And Murphy's sign comes in exam. We all should know the Murphy's sign. What is the Murphy's sign is cannot take a deep breath when examiner are passing below the hepatic region because of pain. I want simple word, pain on palpation. Are we clear? So when the doctors are palpating the hepatic area, patient complains a lot of pain. Are we clear? So what is the sign is? Anytime question, Murphy's sign comes where? In cholecystitis. What is Murphy's sign means is pain on palpation. So very good, and that's a Murphy's sign. And where is the mass? You can feel in the right upper quadrant. Where is the pain is going in cholecystitis is on the right upper quadrant radiating to the scapula. That's important here. And what does it cause here? In the Murphy's sign, the second line, but it's not Murphy's sign, but is the sign and symptom. Patient may have fever because they have infection, dehydration if they are vomiting, and abdominal distension. Cholecystitis, it can lead to obstruction and underlying biliary. What is biliary means? Bile. And what is it can lead to be bile obstruction? Underline the word jaundice. And what kind of color of the urine would be more orange, dark color, foamy urine. So remember, because of jaundice, the color of the urine would be changing, and also when we have jaundice and problem with liver is causing what? Is itching. The word is called pruritus. So what is pruritus is? Itching. Next is, so what are the signs so far? We said pain in the right upper quadrant, Murphy's sign we should know, and jaundice. And when you have jaundice, the color of the urine and leading to pruritus. Now what do we do our patients when they have cholecystitis is, number one, how do you diagnose them? Ultrasound. Write down the word diagnosis by ultrasound. And what do we do? The treatment. Patient has a pain. As when they come in, remember, patient has to be NPO, number one. And we already said earlier, for when patient has pain and a problem in GI, what do we put them here? NG2. And why do we put NG2? Maybe for suction, or another word is called decompression. What is decompression is again removing the fluid or like suction. And for severe cases, why? Because they're having nausea and vomiting. So nausea and vomiting patient is having, What do we do? Number 1, NPO. Number 2, NG2 for decompression. Wording is important. Decompression and suction is same word. Antiemetics. What is antiemetics are for nausea and vomiting. Next word, pain medication. What pain medication you're going to choose? In the next line, Demerol. So what do you give for pain? Your medication would be Demerol. Why? No morphine, because it caused the sphincter and the spasm on the sphincter of OD. So you have it written here, and you can highlight the word Demerol. So what pain medication you're going to give here? Demerol. Why? Because they have spasm of the sphincter of OD. What diet are you going to teach your patient here when they have gallbladder problem? Is the fat. What diet we cut down? Fat, underline. And what are we cutting down here? Gas-forming food. And what are the food you avoid more is fattening food are eggs, all are creams, and fried food, dressing you avoid. Those are very high in fat. Now, when they give you a question, patient is going for cholecystectomy. The meaning is cholecystectomy, removal of what? The gallbladder. When you're removing the gallbladder, patient is going for surgery. Cholecystectomy means common bile duct, and they're removing the stone. Now, next page, if you move on, page number 10, we are talking about laparoscopy. Everyone should know when they are removing cholecystectomy is done surgery. Also, it may be done laparoscopy. What is the word is laparoscopy? Is the laparoscopy, everyone should know, should be done for diagnostic purpose or removing the gallbladder. Whenever patient come back from laparoscopy, where would you see small incision? Right down there on the abdomen, 3 small incision. So what is laparoscopy? This question do come in exam. We all must know what is laparoscopy. Laparoscopy is not a big major surgery. They're having a small incision. Patient is not staying in the hospital for a long time. And what do you monitor patient here with laparoscopy? Small incisional, 3 maybe small area. If they have done a cholecystectomy, they have a bigger incision. That's a bigger surgery. Also, I want you to add here, what do they use in laparoscopy? Add their CO2. CO2 is a gas, carbon dioxide. CO2 is carbon dioxide. So right down there, carbon dioxide is used. What does patient complain is pain. And what do you do here when patient come back after laparoscopy? Add there, ambulate the patient. And what does it help to reduce the pain and reducing the CO2? Everyone is okay, laparoscopy can be done for diagnosis purpose. Laparoscopy can be done surgery. What do you teach your patient when they have cholecystectomy or laparoscopy? Very important. Remember, a gallbladder and pancreas, they're very close here to the chest cavity. And when you have severe pain, what happens? We don't want to breathe hard. And what will happen when you're not breathing? Pneumonia. So your questions are going to be, patient is admitted with cholecystitis. When I go in pancreatitis, what do you teach our patient? Deep breathing exercise. What are we preventing here? Pneumonia. So right down there, and cough, deep breathing. Splinting. What is the meaning splinting? We are supporting the abdominal incision. So what does that mean, splinting? When they're coughing and deep breathing, the pain is not going to hurt and prevent them. Remember the word dehiscence. It doesn't open up the suture line. So what do we do here? Splinting. Medication for nausea and vomiting, antiemetic medication you will give them. Next is NPO, patient would be, and pain medication. I want you to write down where it has T-tube, is surgery is done, cholecystectomy. Cholecystectomy means now they have done bigger surgery. One, I said laparoscopy, another word is cholecystectomy. What is cholecystectomy? Is bigger surgery. And what does patient come back after cholecystectomy? Underline the word T-tube. So what is T-tube is saying is for the drainage. And what do they attach with T-tube is Jackson Pratt. Write down the word T-tube, and what drainage they attach here, Jackson Pratt. Jackson Pratt are attached with the T-tube. And why do you keep T-tube? If there is a question, and we must understand why, is to preserve patency of the duct and ensure the drainage of bile. What is the patency? Means keep the tubing open to drain the bile until, how long do you keep the tube? Until edema resolve. How long do we keep the tube? Until edema resolve. So that's important. And how does it drain? Underline the word gravity. So where do you see T-tube? Patient with cholecystectomy. And what is the T-tube is helping here to drain the bile. Now what position do you put your patient after cholecystectomy? Underline semi-Fowler's position. What position are we putting here? Semi-Fowler's. Next is, what are you monitoring? The drainage, color, and monitor the skin. Make sure you keep at the level, below the level of the stomach so they can drain. And when do you clamp the tube? So remember your question. Your patient is coming back after cholecystectomy. Your tube must not be clamped. Everyone is okay? It's open. When do we clamp the tube? Underline the word before patient is eating and when the doctor has ordered. What do you do? If patient complains nausea and vomiting and you clamp the tube, you unclamp the tube. So if patient complains, I don't feel good, that means you may have to unclamp and also monitor any sign of infection. Everyone is okay? We talked about cholecystitis word. What diet we cut down here? Fat. What surgery is done? Laparoscopy. What is another name of the surgery? Cholecystectomy. What do we have patient with cholecystectomy? T-tube. And T-tube is attached with what? Jackson Pratt. And what do we have to do? We monitor the drainage, make sure the bag is below the level, and unclamp. Clamping, it's unclamped. Only you clamp when the doctor has ordered. How long do we keep the tubing? Until it's allowed the bile to drain, until the doctor has ordered. Now I will move on, pancreatitis word. What is pancreatitis is here is patient has a problem with pancreas. Now what are the reasons for pancreatitis? Are alcohol, infection, viral infection patient has, and is affecting the gallbladder. So patient has problem with the gallbladder and the pancreas. Pancreas is also caused by viral infection, alcohol, and hyperlipidemia. Patient has ulcer, can also lead it, and sign of is pancreatitis. Now where is the pancreas is? Everyone should know on the left side. Are we clear? Now, I said liver and gallbladder was on the right side. Pancreas is where? On the left upper quadrant. Everyone, we must know what is the function of pancreas is. What is the pancreas is helping us. What is the function of pancreas? Where do we get insulin? Where do we get insulin? From pancreas. What else do you get from pancreas? Pancreatic enzyme. So make sure we write down the word. On the top is immediately you see pancreas is producing insulin and pancreatic enzyme. And where is the pancreas is on the left upper quadrant. Now where is the pain? Underline the word left upper quadrant, and is going where? Radiating to the back. And is get worse pain when you're eating fatty food or alcohol. Very important, the pain gets worse. When does the pain gets worse? when patient is laying in recumbent position. What is the meaning recumbent position? On the back. Now what happens when patient lays in back and patient comes in and says, when I am laying in a back and recumbent position, my pain gets worse. Immediately your answer would be, patient has what kind of pain? Pancreatitis. Why? Because they are stretching the abdomen, and they have a lot of tenderness, and it causes pain. What would be the best position? Patient says, when I'm laying down in fetal position, my pain gets better. So everyone make sure is fetal position is good for the patient to relieving the pain. And when does the pain get worse? In recumbent position. Now, second thing I want to remember, Cullen sign and Turner sign. Now the other one we said Murphy sign. Now here we have Cullen sign. And everyone must know when we see patient has Cullen sign, Turner sign, what patient has a problem? Pancreatitis. What is a Cullen and Turner sign are? Underline the word discoloration. And where? Underline the word pre-umbilical area. Around the umbilical area, patient has bruising or discoloration. What is your Turner sign is blue discoloration on the flank area. I want you to write down patient is bleeding. So immediately now you are getting the information when patient has pancreatitis. What is pancreatitis is affecting? Number one, insulin. Number two, digestion. Why? Because they are producing pancreatic enzyme. What are the two signs I hear in pancreatitis patients are Cullen sign and Turner sign. And why? They're bleeding. Everyone is okay bleeding question? Because they may say patient is on injection. What do? They didn't give Cullen sign. Apply the pressure. Their risk of bleeding. Are we okay? Cullen sign and Turner sign. They're losing weight. And position, we already said, recumbent position is not good. Pancreatitis means infection. White blood count is high. Underline the word glucose. What do you check? Blood sugar. What do you check? Lipase and amylase. And that is your pancreatic enzyme. What is pancreatic enzyme? Help in digestion of fat. Again, they have low calcium. Everyone must remember few wording. Pancreatitis, first thing, where is pancreas is on the left upper quadrant. Pain gets worse in what condition? When they're laying on the back. When does they feel good? When they're turning on the fetal position. What are the Cullen and Turner sign? Bleeding sign. What are the patients we are monitoring here are for bleeding, Cullen and Turner sign, and also we said they have infection, fever is high, lipase and amylase, those are pancreatic enzyme, and also they have low calcium. Anything with the GI is calcium is affected. Diagnosis, how do we diagnose them? Number one, white blood count. Whenever there's infection, the white blood count goes high. The normal white blood count, we all should know, 5 to 10,000, and more than that, there's a sign of infection. Amylase and lipase are affected, glucose level is affected. Last word, very important to diagnose, I said earlier in the morning, ERCP. What is ERCP? Endoscopic retrograde cholangiopancreatography. And that is what patient has to go. What do you do when patient comes with pancreatitis? Very important, first thing, don't give food. And what do? NPO a patient. What is the second thing we remember is NG2. What are we inserting here? NG2. I want you to write down on the top maybe IV or maybe TPN. So TPN is total parental nutrition. IV maybe is given to the patient, but first thing, don't give anything to the patient by mouth. Nothing by NG2. Why? Because food is going in the stomach, the pain is going to get worse. So either you're going IV, TPN, and that means NPO. What would you give for pain medication? Underline the word Demerol. What medication? You will keep it available because of low calcium, calcium gluconate. What is pancreatic enzyme here? Is Viokase, Viokase. So when you're giving Viokase, that's a pancreatic enzyme. When do we give pancreatic enzyme? With food. Everyone is okay? And also you are adding with pancreatic enzyme fat-soluble vitamin. What are your fat-soluble vitamins? Are A, D, E, K. So what vitamin do you give them? Vitamin A, D, E, K. And also insulin maybe patient would need. And cimetidine is Tagamet. And also I want you to write down underneath pancreatitis question, what do you teach patient? Deep breathing exercise. Everyone should know what exercise we give them, deep breathing exercise. Why? To prevent pneumonia. Next page, we will move on, is chronic pancreatitis patient. Also, they have in the first line steatoria, fatty stool. And what kind of stool? Steatoria is foul smelling and they're not digesting fat. They're losing a lot of fat. And they may go in jaundice, muscles, they are losing muscle wasting. Intervention are, we already said, decreasing for them are fat and protein, and avoid any kind of alcohol and caffeine. And also monitor for bleeding here. Now in the underneath here, on this page, we have little bit about hepatitis. We all must know your isolation when patient has hepatitis infection. Number 1A and E. What kind of precaution? Contact. B, C, D, write down, is standard precaution. B, C, D are with the blood. A, E with fecal oral. So you got to have is contact precaution. Now, next is just to understand any question with hepatitis, a patient has, what do you monitor? Early sign, they call the word pre-icteric. Icteric word they use for like more like a jaundice symptom. So what is pre-icteric stage are flu-like symptoms. So they feel more flu-like symptom, but very important, they have nausea and vomiting. And underline the word polyarthritis. Icteric stage, whenever we see icteric, mean they can see more jaundice. And when you see jaundice, the color of the stool is dark and urine would be more tea-colored. And what would be high in the blood? Bilirubin. So what is icteric stage? Like now you can see more jaundice. Are we clear? That is in hepatitis. Number 3 is post-icteric. Now they're getting better, energy level is good. Any question, patient is admitted with hepatitis, what would you do as a nurse? Number 1, they get very easily tired, bed rest is important. For diet question, never give fat, but what do you increase? They need energy. Underline the word carb. What are we increasing here when patient has is hepatitis, carb, but what do you cut down here? Fat, so low fat diet. And also increase fluid. And if they say increase juice, that's okay. Juices are more with carb and energies. So we are cutting down fat, but we are increasing here our carb. And hand washing is very important for patients. And pruritus, lotion you can apply. And bathroom must not be shared. Washcloth, towel, anything, their patient articles must not be shared. Avoid alcohol and increase activities slowly. Patient is going home after hepatitis, what can you teach them is very important is activity very slowly because they don't have much energy level. So increase activity slowly. And informed healthcare profession that they have history of hepatitis. Next page, I'd like you to just know, I had it here, whatever we can remember is good, but we must know is a lot of infection control. We must know as the nurses, if we have hepatitis A, what precaution? We said contact. How does it spread? Underline the word fecal oral. That's important. The third line How do you know patient has hepatitis A? Underline the word HAV antibodies in the serum, means in the blood. So what do they see? Antibodies, HAV is positive. How do you treat them? 2 doses of hepatitis vaccine, or they will use the word Havirix, Havrix. How many doses you give? 2 doses. First dose for adult, as we are homosexual, traveling time, poor hygienic countries, healthcare workers, important. Second dose, so how many doses? 2 doses. First dose for high-risk people are, and second one, when do we give? 6 to 12 months. Now the last line, serum immune globulin, for when do you give? A patient is exposed with hepatitis A. What do we give them? Serum immune globulin within time 2 weeks. So everyone, because infection control is high, I advise we must know how many injection we can give. Is 2 is hepatitis vaccine or Havirix. When we are giving for somebody who came in contact, within 2 weeks you can give them immune globulin. Hepatitis B. What is hepatitis B? Is in the blood. How do you know? Is HBsAg in the blood. And then what do you do for prevention hepatitis B? We say is hepatitis B vaccine, one word. Hepatovax we have, and also Ricambo virus. So you can give hepatitis B, Hepatovax and hepatitis B vaccine. How many doses do you give? First dose and second dose should be given after 1 month, and third dose should be given after 6 months. Everyone is okay? How many doses for hepatitis B? 3. So you give first dose and second dose we give after 1 month, and third dose we give on 6 months. Alpha interferon for chronic hepatitis B. Now, last line, hepatitis B, underline immune globulin, those who have never been received and they are exposed. So what do you give them? Immune globulin. Sometimes, mostly in your answer, immune globulin, but also it's called HBIG. Hepatitis C, what do you give them to prevent? Alpha interferon and ribavirin. Underline those 2 wording. Hepatitis D, alpha interferon we can give. Hepatitis E, you will go is hand washing is important, and immune globulin you can give them after exposure. Now I will move on, ulcerative colitis. Now there are few diseases we must know. Here is ulcerative colitis. When patient has ulcerative colitis, the meaning is there is inflammation. And where does inflammation start? In the colon and rectum. So the diseases, we have talked a lot of things, but ulcerative colitis, next word, is infection and inflammation. What is ulcerative colitis? Inflammation. Everyone is okay? You guys are okay with ulcerative? Are we missing the page?
It's right after hepatitis E.
Hepatitis after E, underneath on page 13. If you look at that, is your ulcerative colitis. You got it? Okay. All right. So what is ulcerative colitis? Is inflammation. Highlight that word. Where does ulcerative colitis start? Colon and rectum. That's important. Is from the lower part, colon and rectum. And what happens when there is inflammation is starting from rectum. Underline the word bleeding. Ulcerative means ulcers. They're bleeding and leading to perforation. 2 words is important. There are ulcer, and ulcer can lead bleeding or perforation. Third line is problem because of the ulcer. They cannot absorb the nutrients. So what is the problem? They're not able, whatever food they're eating, they cannot absorb. So absorption problem. And underline the word weight loss. They're losing weight and low calcium. And what kind of stool they have is diarrhea, but underline the word blood. So remember, ulcerative colitis, diarrhea with blood, and since they're bleeding, they're losing weight, and also is anemia. We must know whenever we are bleeding is anemia, vitamin K deficiency, and abdomen is tenderness. How do we diagnose ulcerative colitis? By barium enema. And what do? They give barium enema, and they're looking inside to see how does the patient has colon. Next is, what do you do treatment? If patient is admitted, number one, NPO. And restrict any activity. Why? Because they have a lot of distension and abdominal pain. So what do you restrict here is the activity, intestinal activity, monitor for bleeding and perforation. Diet. What diet do you go here? Low residual. What is the meaning? Low residual means low fiber. So what diet we are giving here? Low fiber. Everyone understand the word colitis, ulcerative means they have ulcer, they're bleeding, what kind of stool they have, diarrhea with blood, and what diet are we giving is low residual means low fiber diet. And second line, avoid any food are causing gas forming food, such as you will avoid them whole grain and nuts, raw vegetable and pepper, any alcohol, any caffeine. So two things are important. Avoid gas forming food, avoid what kind of food? Fiber. And what are you monitoring here are the bleeding and anemia and weight loss. In surgical procedure, in GI system, we have the word ileostomy. What is ileostomy means? They have opening made into where? Small intestine. And what is the word is called? Ileum. Ileostomy means opening in the ileum, and colostomy means colon. And that means they have made opening. Cock ileostomy word, underline the word pouch. Now mostly you will see the bag outside. When they're saying cock pouch means intra-abdomen, inside the stomach. And what do they place here? Underline the word pouch. So everyone is okay. Ileostomy means in the ileum, they're opening in a small intestine. Colostomy means in the colon. When they're saying the word cock pouch means, underline the word abdominal pouch that store the feces. And how do you open? Underline the word nipple and valve. There is a valve and you've got to open it. And how do you empty the cock pouch? Through the catheter. Are we clear? So what do they use to empty? The catheter. Everyone should know the word cock pouch is intra-abdominal pouch, and how do they empty those pouch are through the catheter. Now, pre-op care, if patient is going for colostomy or ileostomy. Number one is intrastomal therapist. What is intrastomal? The person who's going to supply them all those bags and teaching them and helping them to take care. So an intrastomal therapist. What diet do you give before surgery? Low residual diet. Low residual means is what? Low fiber diet. Next is number two, antibiotic may be given. Number three, enema before patient is going for surgery or laxative. After patient come back, colostomy is very important. Number one, what do we apply on the colostomy is petroleum gauze over the stoma, and once you remove the gauze, followed by a sterile dressing, a pouch system is not used. What is the pouch means? The bag. If the bag is not used, you are covering with what? Gauze. And what is they have? Vaseline gauze. Are we clear? Or petroleum gauze. And how do you change the sterile gauze? Number two, pouch system on stoma. What is the meaning pouch? The bag. As soon as possible, and when the doctors or the patients are ready, we start using what? The pouch on the bag. Number three is size. When patient come, the size of colostomy and ileostomy is bigger. Patient says, I never expected that big size. Your answer would be because there's a lot of swelling. Once the swelling subsides, the size of stoma is going to be smaller. Everyone is okay? Stoma size would be bigger early, but as the edema subsides, the swelling is going to subside. What do you monitor here? The color. What is the normal color for the colostomy or ileostomy? Pink or bright red. That means it's good. Pink color is, if it is pale color, that means low hemoglobin. If it is a black or purple color, they are compromising circulation. Everyone is okay? What is the normal color of the colostomy? Are going to be the pink and the red color. And the size will be decreasing. Now I want you to go on next page, and we have said intermediate care. Solid stool is liquid. Remember, in the large intestine, we have ascending colon. Ascending means going up. What is the large intestine does? What is the large intestine does? Absorb the water. So if you are having opening in the large intestine, the stool are going to be very watery. Depend where is the colostomy. So if they have ascending, underline going up, stool would be liquid. And liquid with the transverse colon, and semi-formed when they're going in the transverse, and then descending, you're going to be more normal. So ascending, transverse, still liquid, descending would be more normal. Size of the bag should fit. Remember, your peristomal area, the bag should fit completely on the colostomy, prevent leakage, and skin care is important. So we must know the skin care for your patients would be important. I think we'll take a break now. Okay, so we'll stop, take a break.